I'm Dr. Fitoussi. Today we're going to have some fun topics. This presentation is called From Media to Medical, and some of you might already know me as Interesting Retinal Cases on Instagram. So this is what we're going to talk about today. We're going to go first over a very comprehensive overview of vitreous detachment and all the complications it might involve, whether it's peripheral tears, the optic nerve, macula, vessels, vitreous hemorrhage, and lattice degeneration. After that, we'll jump into a case of an unusual macular degeneration in a young patient. And after this, we'll take a break of the hard knowledge and do something a little fun, which is how to take beautiful pictures of the anterior segment and also the retina using your smartphone. And finally, we'll finish with a case that is a melanoma masquerader in a young patient. So a little bit about me. I'm from Paris, France. I was living there until I was 19, 20. After that, I moved to Israel, where I started my journey in optometry at Bar-Ilan University, College of Optometry. That's a picture of me when I was a student. I was like 20 years old. And well, as you may know, the spectrum of practice is a little different in different countries. Over there, I was doing refraction mostly, and I was interested in disease. So I looked up some options, and I ended up arriving into to Florida. I went to school at Nova Southeastern University College of Optometry in Miami, Florida. It was great days. I've learned a lot. And after I finished after I graduated from school, I did my residency at Bascom Palmer Eye Institute, which is the residency. Really, if there's any student here, I really recommend you do a residency. I think I can attribute at least half of my knowledge due to that residency. It was really amazing. Now I work at a company called Blinking Owl Eye Care. This is my staff. You have the opticians, the technicians, etc. On my free time at work, I spend time educating my technician. I love doing this. They're all pre-optometry students, and I'm trying to give them as much knowledge as possible so then they can get into optometry school and have an easier journey over there. And on my free time, I go by the name Interesting Retinal Cases on social media. I post about all kinds of topics, mostly about the posterior fold and the retina, because this is what I like. All right, so let's get into the first topic. We'll talk about all the potential complication that happens from vitreous detachment. A little review of the attachment of the vitreous. The vitreous is attached to 5 to 6 places. The strongest is the vitreous base. This is where we get those peripheral tears. After that comes the posterior capsule of the lens. A third attachment is the optic nerve, then the macula, then the major retinal vessels. And in those who have lattice degeneration, there is an attachment of the vitreous at lattice degeneration, which is why it is so problematic. We'll get into further details in a bit. So we're born with 100% gel-like vitreous, and as we age, the gel becomes more and more liquefied. And in fact, the liquefaction starts at around 7 years old. It starts centrally, as you can see here. And as the time goes by, those pockets of liquefied vitreous progresses further to the periphery. And that's when vitreous detachment happens. So as the liquefaction happens centrally, eventually, like I said, it progresses to the periphery, and it will separate the vitreous cortex, which is a gel-like vitreous, from the retina. And that's when the vitreous detachment happens. So we have here a beautiful graph that shows the progression of the vitreous over time. We can see that at birth, we are at 100% gel. And around 7, 8 years old, liquefaction starts to happen. It stays pretty steady until we reach the age of 40, 50, and then liquefaction starts to get more and more, and we get vitreous detachment eventually. All right, so how does vitreous detachment impact the eye? Vitreous detachment, in most cases, is a benign process that happens. However, in some cases, it can cause some vision-threatening complications. So they've done a study on 8,305 patients that presented with acute PVD symptoms, meaning flashing lights and floaters. And they found that out of all those people, 5.4% had a retinal tear and 4% had a retinal detachment. The patients that were more at risk for this were the patients that were male under the age of 60 years old. So let's start with the least clinically important, the posterior lens capsule. That's the second attachment of the vitreous. It's a strong attachment. And the vitreous is attached over there by what we call the retrolental ligaments. And when it separates, even if it's pulled a little hard, it has really no complication on the lens or the vitreous itself. Now the optic nerve, it is a strong attachment. It is attached to the margins of the optic nerve. And when it separates, we have the classic finding that we know as the Weiss ring. Now the Weiss ring represents the previous attachment at the margin of the nerve. That's why it takes a circular pattern. And well, the symptoms may include flashing lights and floaters. So the floaters that are created by the Weiss ring, they're a little different. They're quite different from the one created by peripheral tears. They will be large, central. They will be circular if we have a full ring, as you can see here, and they will be fewer in numbers. If we compare that to the floaters we see in peripheral tears, those floaters will be more numerous and they will be smaller because the floaters caused by peripheral tears are essentially the pigment released during the tear, and they will just scatter all through the vitreous. They will be very small and they'll be much more numerous. So that's a good question to ask a patient. When a patient shows up and say, hey, I started having floaters, you need to ask, how many floaters do you see? You see 2, 3 floaters, they're large and central, or do you see 100 floaters? Right? That can help you differentiate just based on the question. Is it more likely to be a benign PVD or peripheral tear? Now, the flashing lights are also different. The flashing lights are caused by vitreoretinal traction. As the vitreous separate, it pulls on the retina, and that stimulation, that pulling on the retina will trigger the photoreceptors. And that's, well, what causes the flashing lights. And that's kind of like similar to that mechanism, that phenomenon we call pressure phosphine. I don't know if you ever tried it. If you press on the side of your eye, you will see a light coming on the other side. This is the same thing. It's a mechanical trigger on the photoreceptors that will create a light effect. So the flashing lights in PVD, they will be brief, they're sporadic, they're more noticeable in dark environments, and they will become less frequent as the vitreous detaches and the traction is released. The flashing light will last days to weeks, and they will go down gradually as the traction from the vitreous on the retina resolves. So it's also a good question to ask the patient when the patient says, hey, I'm seeing flashing lights. Very often they're not showing up on the first day when they had those symptoms. They show up a few days after. So you can ask, how are the flashing lights evolving? Is it getting less and less? Is it the same? Is it worse? So if it's resolving and it's getting less and less, you can assume that you're more likely looking at a benign PVD.
Dr. Fitoussi, from a clinical perspective, asking you 2 questions just from your general patients. Your patients ever ask about removing the floaters? Do they ever become fastidious with it and they ask, oh my God, what can I do? And what's your clinical pearl, or how do you usually advise them in regards to it?
They very often, they're like, oh my God, I don't know what to do with it. How can I get rid of it? The problem, well, there are 2 ways to look at it. Number one, the floaters, they may sink, they may go down over time and the patient will notice it less. And also the brain may adapt to it and just ignore that image over time. Now, if they want to remove that floater, it's pretty complicated because they have to go to surgery. They will have to do a vitrectomy. I've heard about laser for it. So because it's so invasive, I don't recommend them to go and get surgical intervention because you might end up with more complication than that single floater that is, in fact, benign.
Yeah. Excellent. And another question I wanted to ask you is, and again, you may be getting into this later, but what's your usual follow-up for patients with the original acute PVD? When do you have them back?
Okay, so PVD is a process that takes about a month to happen. So you can consider that if you follow a patient for about a month, once you get at that month landmark, the the patient is out of the woods, is no more at risk for tears. So what I typically do, I see them on first day. Then if the symptoms are a little more intense, I would see them 1 week later, and then I do 1 month. Once that month is over, they're not more at risk anymore. And also, studies have shown that if at the first encounter, if there is no tear at the first encounter, the risk for tears in the following weeks is much less. So the first presentation is really the most important.
It's actually one of the greatest clinical pearls I had heard for a long time. It's a very good point, particularly because a lot of these patients, it's almost as if you give yourself 2 weeks, you're giving yourself a second chance to find that tear, which you may have potentially missed, or it might be smaller during the time that you initially saw it. But usually it's far more common during the initial stages. So very good clinical pearl there.
Exactly. Also, I want to add that PVD, the process of vitreous detachment, it's a process. It doesn't happen one day to the other. So even if there were no tear on day one, the vitreous will keep pulling on the retina. So a tear can still happen a week or two after that. So yes, we want to follow, maybe we miss a tear, but also the tear can happen after the first visit. So that's one of the reasons we do the follow-ups. All right, so this is just an OCT that shows the attachment of the vitreous at the optic nerve. Like I said, it's attached to the margin of the nerve. You can see here the attachment and over here. So the vitreous base, this is the strongest attachment of the vitreous. It covers the posterior 2 millimeter of the pars plana and the beginning of the ora serrata. And because of its strong attachment, the separation over there can cause significant traction at the retina. Now, same thing, the flashing lights are occurring because of the same process. The vitreous pull on the retina, it triggers the photoreceptors, and you see flashing lights. So the flashing lights should decrease in frequency as the vitreous separate. And we can say that the risk of tears after the vitreous has let go of the retina is drastically less. The patient will be a much less risk of a tear after the PVD has happened. So sometimes the vitreous doesn't separate in a smooth pattern. And well, the peripheral retina it's thin. It's not as thick as the posterior segment. And I looked it up, and the peripheral retina is about the thickness of the fovea. So that's pretty thin. And over there, since the vitreous has such a strong attachment, this is just a bad combo. That's why patients are at risk for of tears, because they have thin retina, strong traction. That's how you get to a peripheral retinal tear. And well, symptoms include the flashing lights and well, the floaters if there is a tear. So the floaters we see in peripheral tears, if you compare them to the benign PVD or the white ring, they will be smaller. They're more numerous, and they're caused by the release of pigments. As the retina tears, that release in pigments in the entire vitreous will just cause the patient to see the shadow of those pigments, and well, those are the floaters. So we can see them, the classic test for this is to look behind the lens. So you dilate the patient, you focus your slit lamp on the posterior capsule of the lens, you push a little in, and you ask the patient to look up, down, and you see the vitreous moving. If you see those pigments, then you know that potentially you need to look very carefully to find a tear. That finding, we call it tobacco dust or Schaefer sign. So a little clinical pearl, there is another way you can use your OCT for peripheral tears is by looking at the vitreous when a patient complains of floaters. And you can see this one is not a great quality image, but you can see some noise. Those dots here, those are the pigments in the vitreous. Actually, you have a better picture here. Here's a patient with a rhegmatogenous retinal detachment. I Googled just rhegmatogenous retinal detachment, and they just want to show that detachment of the retina. But what they didn't mention is that we can see the pigments here, 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 and here. This is essentially tobacco dust that we can see at the back of the eye on the OCT. So once you see this, that's another indication of potentially there is a peripheral tear.
And just to add with the vitreous, when you're looking back there, The other real relevance is, because it's a little bit hard to tell the difference after you've seen so many, is red blood cells. So just from the tear itself pulling on a vessel, you get these little RBCs, and that in itself gives you that shower of floaters, which is much more consistent. But that clinical pearl that you added, for those of them who have an OCT and take a look at acute PVD, it's actually of great value. And there's been numerous studies that have shown the increased prevalence of retinal breaks when done that. So another great clinical pearl, particularly for those who have no OCT.
Especially because OCT now is getting a better and better quality, so we can really have a clear image of the vitreous now. All right, so flashing lights in peripheral tears. If we compare that to the benign PVD, those flashing lights will be more intense, they will be more frequent, and they will be persistent until the traction is relieved at the area of traction.
So you mentioned that 1 month period. Now, I've had patients plenty who have had those flashes continuous. Do you still see them? Or do you kind of just say, okay, it's been a month, or now it's been 2 months, I'm done? When do you make the call?
When there is no tear, you're saying?
Well, yes. So basically the patient has continuous flashes, but you still never found a tear. On repeated examinations, you felt comfortable. I would urge also for those out there to always do a sclerodepression. Even if you are not great at it, the more practice you get, the better you get, because the dynamics of that retina is seen dramatically different with sclerodepression. And honestly, within the American Academy of Ophthalmology is written that a sclerodepression should be done, whereby in the AOA, it's actually not necessarily written. It says to be used when you feel necessary. But do you ever give the perspective of, okay, I'm done. It's flashes after flashes. I've followed up. Is there a timeline for you that you can guide some of the audience here?
So if you think about it, the flashing lights mean there is still traction. So if there is still traction, I would follow for a little more just to make sure that traction doesn't eventually lead to a tear. I haven't had a patient that had indefinitely flashes of light. Eventually it resolves, but I would follow at least once in a while to make sure that nothing happened, because, well, flashing light means traction. So I would be careful here. All right, so when a tear happens, there are two options for tears. We have the classic horseshoe tear right here, and that has this flap that is still attached to the retina. And the second option is an operculated hole in which that flap got torn away from the retina and is now floating above. You can see here the shadow of it. And the question is, which one is the worst, or which one has the best prognosis? So if you look at the horseshoe tear, those tears are caused by uneven traction of the vitreous on the retina, and this will cause a horseshoe tear that is typically U-shaped or triangular, you can see here. And the apex of the tear will typically be pointing toward the posterior pole. You can see here the optic nerve macula there over here, right? Now, the problem with those tears is that as the tear happens, very often the apex, the pointy part of the flap, remains attached to the vitreous. And this is no good, because not only we have now an opening on the retina, which will allow the liquefied vitreous to penetrate through, go under the retina and lift, but on top of this, we have persistent traction of the vitreous on the retina that will kind of like try to trigger a retinal detachment. Now, the other option is the operculated hole. The operculated hole happens when there is an even traction on the retina, and, well, it will tear the flap away from that retina. Now, that flap that was torn is now called an operculum, and the good thing about this is that the vitreous doesn't have any ability to pull on the retina because the traction was relieved. So this is a better scenario, even though there is still an opening, but at least there is no more traction. Now, the patient is still at risk for detachment. I mean, the liquefied vitreous can still penetrate through that opening, go under the retina and lift it, but it's a better scenario if you compare that to the horseshoe tear.
Dr. Fitoussi, to go into that excellent picture that you have there, because I think it's a great perspective. You got and if you would for me, kind of show it with your arrow, you got your big operculated hole, and it's a larger hole. There is, as you already mentioned, some small fluid cuff around it, not necessarily a retinal detachment, but there's definitely subretinal fluid, which is the whitish area surrounding it.
Right.
Right adjacent to that, further out, first there's a black area, which actually gives you a perspective. The little black area on the inferior is actually pigment. And this is a bit older, even though it's large, it is older. So this can go either way from a retinal specialist point of view, to treat or not to treat, given the fluid, yet it's old, but it's large. The area right behind it, just like you mentioned, is the shadow. And the little tiny thing furthest away is actually the operculum. And another clinical pearl that could be alluded to, as you had mentioned about the full hole taken off, is the 1/5 rule. This little tiny operculum, which is way out in the periphery, is 1/5 the size of the actual hole, which signifies, along with the small pigment, that this has been more of a chronic entity. So don't be surprised if a retinal surgeon may not treat it, but there may be others that might. And just like Dr. Fitoussi had mentioned, symptoms is always probably the primary thought process in regards to treating or not. So excellent pictures and excellent clinical pearls.
You're saying, I just want to clarify, you're saying that the operculum will shrink over time, like a shrink and a pigmented operculum is a sign of chronicity. Is that what you're saying?
Yeah, the pigment aspect is not really operculum, it's just pigment surrounding it, but it could be within. The operculum is completely divulged. So
Yeah.
right behind it, there is a shadow. And the last one is actually the floating operculum. And if you notice, look how tiny it is in comparison to a much larger hole. So because the tissue is not being fed by the retina over time, it will shrink. So it's a great example of an older one, but yet, like you mentioned, there's still fluid in the subretinal space. So this can go like both ways. It's an excellent picture to kind of signify the fact that it can kind of go both ways in this particular case.
Right. Okay. Great. So the process of a rhegmatogenous retinal detachment, I mean, we just said it, but once a break happens, the liquefied vitreous can penetrate through that break, get into that subretinal space, and it will start lifting the retina, which is the cause of detachment. Now, here's another number I found in another study. They say that 10 to 15% of the patient presenting with acute symptomatic PVD, meaning flashing like floaters, will have a retinal break. So now the weakest attachment of all, the retinal vessels. This is the fifth attachment. And sometimes when the separation of the vitreous from the vessel is not smooth, it can pull on the vessels. And sometimes when it pulls strong enough, it can rupture that vessel, causing a vitreous hemorrhage. This is what we see right here. Now the density and the location of the hemorrhage can vary. And here's a very interesting, very important clinical pearl. An acute symptomatic PVD in the presence of a vitreous hemorrhage increases the chance of concurrent retinal break to 70 to 95%, meaning if you have a patient that shows up with PVD symptoms and there is a vitreous hemorrhage, you know that statistically, you might have a tear somewhere. So you got to be really careful with those vitreous hemorrhages. The symptoms in those hemorrhages depends on the size of the hemorrhage. If it's a small hemorrhage, they'll have just floaters, a little red hue, haze, etc. And if it's a more advanced hemorrhage, you'll have a decrease in visual acuity, visual field, and scotomas.
If you can't get through a view, that's a great, like you showed the ultrasound, so that was actually perfect. I was going to say, if you can't get through a view of that example right down there, you need to get that second opinion. And if you don't find a break, I urge you to get a second opinion, because the odds are, as Dr. Fitoussi had mentioned, they're against you. So you certainly don't want to be the one following this patient up and then resulting in a problem. But if you can get a picture through a vitreous hemorrhage, and let's say it's not a PDR case, that really needs to be a more urgent entity at hand, because chances are there's a break and or detachment, and ultrasound needs to be done.
Yes, I've seen a vitreous hemorrhage secondary to PVD that was observed by another doctor, and the patient showed up a week later or 2 weeks later, and the blood kind of like coagulated, and then I could have a view because the previous doctor didn't, and I found a tear. So yes, I would say B scan, which is what we are going to look at here. The management is B scan ultrasound to rule out tears or detachment. And tears can be seen on B scan. I mean, I have a friend, she's a B scan tech, and she's really good, and she can pick up the smallest tear. So it's not just detachment, tears can be seen on B scan. And well, Post-planar vitrectomy is kind of like the treatment for it, depending on the situation. But if there is either a tear or detachment, or if the vitreous hemorrhage is not resolving, post-planar vitrectomy probably is the way the surgeon will go. Now, lattice degeneration, it is a strong attachment. It's found in 6 to 8% of the population. However, it increases to about 33% in myopes. And this is one of the reasons why myopes are more at risk for tears and retinal detachments. Now, only 1% of the patient with lattice degeneration will develop a detachment. However, the contrary is not true. When we look at patients that have a retinal detachment, lattice degeneration will be present in 20 to 30% of these patients. Now, here's a beautiful image of lattice degeneration seen on histology. And they've studied that, and they found that there are 3 findings that are always present in lattice degeneration. The first one is retinal thinning. After that, it's vitreous liquefaction over that area of thin retina. And the last one is tight vitreoretinal adhesion at the margins of the lesion. And we can see everything here. This image shows here, the bottom is the choroid. In between, this is space. This here, all the way here, is the retina. We have healthy retina, and we have the area of lattice that goes from here to here. We can see thinning. Now, on top of this, we have, over there is the vitreous. So this is the normal vitreous, and this is the area of liquefied vitreous overlying that area of thin retina. And the last one, we said tight adhesion at the margins. Well, here it is. You can see the retina is being pulled at the edge of the lattice degeneration.
And that's a great example as to why the lattice becomes, are you worried about lattice? I mean, you see high myopes, you deal with myopic control and various other entities. So you're proposed to see a lot of these patients and see quite a bit of lattice. Are you worried about lattice for the most part?
Listen, I'm worried when it gets to around the age of PVD, because that's when the action happened.
So it's a tractional component and not the lattice in itself that becomes.
That's right. Well, the risk for them is, if you think about it, lattice, it's thin retina. I mean, the periphery is thin to start with. If on top of this, you have extra thinning and a strong adhesion, this is the perfect combo for a tear. So yes, I'm worried about them. I give them the retinal detachment, precautions, flashing floaters, and I just tell them to be careful.
But I want people to understand that lattice in itself, like you mentioned, during the PVD process, 100% agree. But lattice in itself, very small chance that usually precludes to become a retinal detachment, even with holes. But the beautiful description that you wrote here, between the traction, that liquefied vitreous in that axis, and during the PVD process, that's when an area of, and it's not necessarily the lattice adheres very strongly. It's the area adjacent to it can cause hair, and that's where the problems would occur. So a great illustration to kind of depict that, particularly, I know we have some students and residents who are kind of, the reason why retinal specialists, and I've been very lucky to work with them for so many years in the office myself, they're so good at what they do is just like you mentioned, they're inside the eye looking at this every day, but layer by layer, traction by traction, where for us, it's more of an abstract imaging to kind of understand what we're looking at. So I really like the fact that you bring in the anatomy and pathophysiology into essence here.
That's right. All right, so sometimes lattice degeneration has atrophic holes, right? Atrophic holes, they represent the end stage thinning of that area, and it rarely progresses to retinal detachment. Now, sometimes there will be a small cuff of fluid around that area of atrophic hole, and it is so that cuff is usually stable, and it is thought to come from that what we just saw here, that area, that overlying area of liquefied vitreous. This is thought, that cuff is thought to be caused by this vitreous that just goes through it and go underneath that retina. Now, the second thing we've noticed is that it seems like there is no communication between that pocket of liquefied vitreous and the greater vitreous here. That's why atrophic holes are not necessarily an increased risk for detachment of the retina. In fact, a small percentage of the retinal detachment are caused by lattice degeneration with atrophic holes. We have here 2.8%. Now, retinal tears in lattice degeneration, we just said it, they stem from the traction at the margin of the lattice. This area is known to have tight adhesion. And the tear is often posterior to the margin, at the posterior margin of the lattice. As you can see here, we have a patient that has lattice degeneration, and we can see that the tear is posterior. That's right here, this area of adhesion. You can see that this area has more traction than the other side of the lattice degeneration. So very often, even if you just Google rhegmatogenous retinal detachment, you'll find very often lattice and the tear being posterior to it. So lattice is more common in myopes, and well, it seems like that's the reason why there are increased risk of detachment. So how do you manage this patient with lattice degeneration and retinal tears, especially after PVD? They are at increased risk for detachment, and these patients require laser or cryotherapy to hold this in place. Now the macula is the fourth attachment of the vitreous. It's a rather weak attachment. It typically happens prior to the optic nerve because, well, the attachment is weaker. You can see here it's attached to the optic nerve and it is detached at the macula. And it might cause, when it is not moved, it might cause three complications. The first one is an ERM, epiretinal membrane. Second one is a vitreomacular traction, meaning traction of the vitreous at the macula. And the last one, the worst case scenario, is a macular hole. So epiretinal membrane is more common in female. There's a ratio of 3 to 2. And the prevalence increases with age. You can see that at the age of 50, the prevalence is about 2%. But as you go to 75, the prevalence increases by 10 times and it becomes 20%. So
you're telling me I still have a chance of not having an epiretinal membrane? It's a very small chance for me still.
What is
I'm on the bottom half and not on the top, but I'm still in the numbers that you mentioned over there.
Somehow I knew that you're going to take that personally.
Of course I am. I feel with my presbyopic glasses. That's how I actually read it. Continue.
It's okay. I'm getting close to presbyopia too. That's okay.
That's okay. Dog ears. Continue.
So those membranes are often they're thought to be idiopathic. However, you will see that it's very often associated with the onset of PVD. Now, the cause of it, what we think causes the membrane after PVD, is during the detachment, the traction of the vitreous on the surface of the retina can cause some small pores, meaning the vitreous is attached by many small fibers on the retina, and when it separates, it creates kind of like small dents in the ILM. And those dents and the glial cells that were left over from the vitreous on the ILM will be the perfect spot where those cells can proliferate and will cause that membrane that we call epiretinal membrane.
And as you mentioned, most of the time, by the time you see an epiretinal membrane, there is already an PVD because you had to have had the actual loss of that area by as opposed to say a flap tear that kind of had the continuous momentum of the PVD process occurring. This will have one floating on top or not even seen in these pictures because it's much further up into the anterior vitreous.
Yes, so PVD definitely strongly associated with the creation of an ERM. So the ERM can be mild or more advanced. If it is mild, that's the picture here we have on the left side. On the fundus exam, it will be fine, glistening, and it will have very little impact on the architecture of the retina. You can see there is a mild ERM here. It folds a little bit the retina, but overall the retina, the macula is kind of intact, and this patient probably has good vision. However, sometimes it gets a little thicker, and we will be able to see those folds that we see right here. This is what we see on this picture, kind of like the wrinkling that is pointing to the area of ERM. You can see here there is the membrane, those folds are pointing here, and here there is a membrane too, and those folds are pointing here.
When do you get a second opinion, or when do you urge the team to get a second opinion on an epiretinal membrane? Because most of them can be followed for some time.
Yes, so I go based on symptoms. If the visual acuity is significantly reduced, or if the patient is complaining of metamorphopsia, I will send them for a second opinion. if I have the OCT and the membrane is mild and the vision is good, I can just follow them once in a while, and I think that will be good enough. Because when we think about it, the surgery to remove that membrane is pretty invasive. So you want to be careful with mild membranes. They're very often, they don't require really treatment.
And usually, like you mentioned, which I thought was a great clinical pearl, it's a metamorphopsia. The visual acuity, yeah, if it's severely decreased, but it's a metamorphopsia that we're working against. A lot of times, even the contour of the retina doesn't change dramatically. Visual acuity may sometimes even be stable, but it's that metamorphopsia that you're going for in regards to a good prognosis and visual function afterwards. So good clinical.
Right. Well. So here we have the management. The management is really based on the visual complaint, right? Blurry vision, metamorphopsia. Like I said, the mild can be monitored, the advanced ERM, whether the vision is poor or not. Typically, during my residency, I would see the retinal specialist only addressing vision that is 20/40 or worse, or if they have significant subjective metamorphopsia, that will be criteria for considering surgery, right? The surgery is typically a postplanar vitrectomy, and they will go and peel the membrane. And interestingly enough, they will often peel that ILM because, as we said, the ILM is kind of like the place where the glial cells can proliferate. So once you remove that ILM, you remove that area where they could proliferate, and you're essentially preventing recurrence by doing so. So VMT, vitreomacular traction, it happens secondary to tractional forces on the macula. You can see that picture right here. And the VMT is characterized by three things. Number one is an incomplete PVD. Two is a strong adherence of the vitreous to the top of the macula. And the last one is, due to the traction, we will see architectural changes of the macula, which is loss of the foveal pit and cystic changes. Now, the VMT may or may not affect visual acuity, depends how bad it is, but overall, since the photoreceptor layer is intact, very often they'll have reasonable visual acuity as long as the traction and the foveal architecture is not too intensely deformed. All right, so macular hole, that's kind of like the worst case scenario that can happen as the vitreous separates at the macula. It's strongly associated with aging. You can see that 83% of the cases happen between 50 and 70 years old. It's more common in female. And you result well from the traction of the vitreous at the macula. Now, there are other causes that can lead to a macular hole, for example, trauma, surgery, inflammation, CME, etc. So it can happen as a complication of persistent vitreomacular traction, and it is bilateral. What happening?
So sorry, Dr. Fitoussi, you can go ahead and proceed and disregard that.
Okay.
They need to answer questions during the polling.
Here we go. Okay, and it's bilateral in 25 to 30% of the cases. Now, we can consider the other eye to be safe once full PVD has happened because, well, the traction has now resolved.
Question again, when do you refer, and I don't know if you're going to review the staging. So I guess we're not reviewing the staging, which is perfectly fine.
Yes, I will review the stages. And I will tell when to refer
within that stage, when would you then when you get to it, I want to know when you recommend getting a second opinion. Obviously, a stage 4 macular hole, 2400, yeah, but I think it precludes us to getting them earlier so you can make your recommendations.
I think the sensitive time is, so as you get the VMT, you don't know what's going to happen as a VMT stage. When you're here, it can go two ways. Either the vitreous let go the retina, and the retina will fall back in, and that's it, the patient is safe. Or it will start to tear the retina, and you start to have a macular hole. It's stage 2, that's when you start to have a small hole. That's when I would refer the patient, because I'll show you in a second that most stage 2 will progress to stage 3. So as soon as there is some type of macular hole that is happening, that's when I refer the patient. If it's just VMT, I can monitor to see if it resolves on its own, yes or no.
So in the good old days, we used to have Jetrea as a treatment options for VMT, which we ended up realizing that at the end of the stage, when we were injecting these patients, they pretty much had a 50-50 chance anyways. And just like you mentioned, even without an injection nowadays, they got a 50-50 chance. So Jeteria
Yeah.
never went anywhere.
Yeah, it was a great idea. It just didn't work, huh?
Exactly. It was a great
Yeah.
idea, but it didn't do anything. But the end thing, when you were talking about the full thickness hole, I think that's really important because just like you mentioned, even that same page on the top, that constitutes to be a small hole. Why? Because the bottom half looks big, but the holes are measured exactly at the aperture. So on the top, this is a much bigger hole. It's a stage 2. This right here would be stage 3, stage 4, whichever way you would see it with the PVD on top. But where the two little mountains meet on that top point, that's the aperture. That's actually where we measure the size of a hole. So that actually constitutes as a small hole, even though the bottom part is pretty big. So that one, visual acuity may actually be relatively good. But as you mentioned, this is a patient that's far more important to refer out, even though it's even a further stage, because it's a small aperture, and then you take out the you would take out the pre-ILM, you take out the vitrectomy, but when you put the gas bubble, those bridges are just going to come right back down and meet. So anything that's got the full thickness that you're seeing through and through, that becomes a staging, just like you stated. So great clinical pearl as well.
All right. So the symptoms for these macular holes obviously will be vision loss, central scotoma, and metamorphopsia. Typically, a patient that has full thickness macular hole will not have good visual acuity because, well, the photoreceptors are now gone centrally. Now, here's a good clinical pearl. A fresh macular hole has a better prognosis if treated promptly versus if you wait a little bit and it becomes chronic. I had this patient a few days ago that presented with bilateral macular hole, and he said, oh yeah, I'm followed by the retinal specialist. He said, let's do cataract surgery, and in about 6 months, we'll see if we want to do a surgery for macular hole. And listen, I'm no surgeon, but I know that a chronic hole has a bad prognosis. So I recommended he goes back to the retinal specialist and see if that's something they can do earlier, because those photoreceptors cannot just be hanging forever. They need to be in a position with the underlying choroid, which is what feeds them the blood supply, etc. So a macular hole should be addressed rather sooner than later.
And over here in the United States, maybe a bit different in Canada, there's a lot of insurance issues. So by the time you send it, we need to get clearance from it. And then my surgeons are still awaiting to get the authorization. So even though you send it promptly, I'm still waiting a few weeks before it goes. So that's another great clinical pearl. It's and I don't mean overnight, but definitely the sooner the better, because there's still going to be a little bit of a delay.
Yeah.
Okay,
and so
this number that you're mentioning, that 400, that's measured at the aperture. So I want people to understand that measurement is that aperture measurement on top. That other little one that you had was probably far less than 400.
You meaning here, when you say aperture, you mean that place here?
The two little points, where are you with that? Yeah, where the two little points meet on the top, not on the bottom aspect. So I'm trying to point at something, but I'm the only one being able to see it on my end. But it's where the two bridges end side meet, that's the aperture measurement.
Okay. So here's the classification made by GAS. I tried to simplify it as much as possible because I personally had a hard time remembering it. We have stage 1, which is the loss of foveal depression. You can see here the fovea as lost is normal dent. Stage 2 is when there is a full thickness hole, but a small hole, which is less than 400 microns. Stage 3 is when the full thickness hole becomes large. And the stage 4 is when there is a stage 3 plus a complete PVD. So here's a clinical pearl. Almost 100% of the stage 2 macular hole, meaning small holes, will progress to a stage 3, and visual acuity will decline further, meaning that relates to what we said about the time for referral. As soon as you see the onset of even a small macular hole, that's when you need to refer. Right? You don't need to wait any further to see if it will improve on its own. So there is another classification. It's a more recent classification. It's done by the International Vitreomacular Traction Study. It came out in 2013, and it separates the stages a little differently. The first step is a VMA, vitreomacular adhesion. This is not a pathological stage. It's a rather normal stage. It's when the vitreous is still attached to the macula and about to separate. Right? There's no distortion of the retina. The retina is unaffected. The next step is vitreomacular traction. This is what we just saw when there is traction from the vitreous at the macula, which changes the shape of the retina. And the last stage is when there is full thickness macular hole. They separated that in small, medium, and large, if the cause was primary, secondary, and if there is presence or absence of PVD. Now, I thought it would be a good opportunity to review the different type of macular holes because it's sometimes confusing. Let's start by lamellar macular hole. This is very simple. It's when there is loss of tissue in the inner layer of the retina only. As you can see on this picture, the tissue that is gone is just the inner part, and the outer retina is still present. This is why this is a lamellar hole, right?
And if you notice a lot of the lamellar holes, point at that. You see how it makes like an anvil shape? So it's got this little corner and then it kind of splits in there. So a lot of times the lamellar holes has an inner and outer split in that area. So in your picture, it's a great representation of that anvil-like shape on it. And these patients may be followed for a long time. Most of my surgeons are not doing surgery on this.
Okay. All right. And also this patient will have better visual acuity compared to the full thickness because, well, the photoreceptors are still somehow present. So the causes, of course, can be a PVD, it can be caused by ERM or chronic macular edema. Now, I found another type. I think it's a recent type of category for those type of holes, and it's epiretinal membrane foveoschisis. And this condition happened because, well, the epiretinal membrane is pulling on the retina and is causing schisis in Henle's layer. And in order to use that term, well, you need two things. You need one, epiretinal membrane, and two, the finding of schisis in Henle's layer. Now we have the macular pseudohole. This one can sometimes be mistaken for lamellar hole just because of its appearance, right? And what's important in that pseudohole is that it does not involve loss of tissue. The retina has not lost anything, but because of its shape, it looks like there is some aspect of a macular hole. Now, to diagnose this, you need three things. Number one, an ERM that is sparing the foveal area. Retinal thickening, this is what we see here, because usually it goes down a little bit. So we see that ERM is pulling the retina up, so it gives kind of like a tall aspect of the retina. And the last thing is verticalized foveal profile. You can see that the fovea is going very straight up vertically. So in that case, just to remember, macular pseudohole is a condition that does not involve loss of tissue. So a little recap on PVD and its consequences. The vitreous is attached in 5 places. The vitreous base and lattice degeneration are strong attachments. The retinal vessels are weak attachments. And as we age, well, the vitreous changes from gel to liquid. Now, the potential sight-threatening complication we can have is, well, the tears in the periphery, an ERM, traction at the macular hole, and a vitreous hemorrhage. Now, I put that interesting slides. I think it's a good slide if you guys want to screenshot it. It compares those flashing lights and floaters from benign PVD to tears. And we can see that in the benign PVD, the flashing light will be less intense, they're less frequent, they will last days to weeks, and then eventually they will resolve. Whereas if we look at tears, they will be more intense and more frequent, and very often they'll be persistent. Now, for the floaters in benign PVD, it's essentially the Weiss ring. You'll have a few floaters, whether the Weiss ring is in one piece or it's broken apart in a few pieces, like 2-3 floaters. They'll be large and they'll be central. Whereas in tears, the floaters will be much more numerous. They'll be small and scattered. This is because the retina, when it got torn, it released a bunch of pigments. All right, any questions so far?
No. You fulfilled all their answers to every one of their questions that they could imagine.
I think so too. All right, so let's get into the first case. This is a 38-year-old male who came from Ukraine, and he presented for glasses exam. His chief complaint was really not impressive. He said, I see blurry on my left eye with my glasses, but honestly, I'm doing okay. I have no problems really. His family history was unremarkable, past medical history, negative, no allergies. and its past ocular history was relevant for macular degeneration diagnosed in the left eye in Ukraine a few years ago, for which he received 2 anti-VEGF injections. So already we know that something is happening in that left eye. The entrance testing, it was 2025 on the right eye and count finger on the left, which did not improve on pinhole. EOMs were normal, visual fields normal, the pupils were normal, and of course the refraction did not improve the visual acuity. Anterior segment was normal, eye pressure was also normal. So here's a picture of the fundus. We can see that on the left eye, we have a large area of subretinal scar. How do I know it's subretinal? Because I can see the overlying vessels, right? We see that the nerves are, they're pretty normal. The cup is reasonable. The vessels are fine. All the action here is happening centrally here in that scar. That also explains why the visual acuity was count finger. And on the right eye, we have this kind of like diffuse, kind of like atrophy. And this area that looks also a little sketchy, that may be the beginning of a subretinal scar. So when we look at those pictures, there is one very subtle finding that if you find it, you get your diagnosis. I'll let you look again. This is very, very subtle, and it might be confused for, you can confuse that with something else. This finding is those tiny lines. Those lines, you might confuse them with blood vessels. As you can see here or here, you can see those lines are not going to the optic nerve. They go here and just don't plug to the optic nerve. And they're here on the right eye as well, here, here, and here.
We need AIs with photos that come with the little arrows every time something's wrong. It just virtually gives you a preliminary answer.
That's my fundus camera. It just comes with arrows, so then I don't have to think too much.
But that honestly, it is it's a great representation. And afterwards, I'm going to be asking you to start think about it in regards to what your workup may potentially be when you have that. But that's a great example of it, because it would have 100% been missed right in between the other things.
Yes. Well, the fundus photo is very helpful because you can take your time and find those subtle findings, whereas probably when they looked at it, because this is a finding that was not picked up before. The patient didn't know about it. He just know he has a problem on the left eye and he doesn't know why. But the fundus photo really allows you to take your time and pick up those subtle findings. So those lines, they're called angioid streaks. Angioid streaks are abnormal cracks in Bruch's membrane. They're typically radiating from the optic nerve, and they're often mistaken for blood vessels, right? And those cracks, when we look at Bruch's membrane, we have here the RPE and choroid. Bruch's membrane is made of 5 layers, and the inner layer is what they call the central elastic layer, and that's where the problem is in those patients with angioid streaks. Now, 50% of angioid streaks are idiopathic. However, the other remaining 50% will be associated with an underlying systemic condition. So there is this mnemonic we use to remember the causes, the potential causes of angioid streaks. If you're a student, try to remember this, PEPSI, and it stands for Pseudoxanthoma Elasticum, which is the most common underlying known cause of angioid streaks. After that comes Ehlers-Danlos, Paget disease, sickle cell, and well, 50% is idiopathic. Now, Pseudoxanthoma Elasticum, since it's the most common, we're going to talk about this. This is an inherited recessive genetic disorder that causes mineralization of the elastic fiber, and this is the most important. That's why all the problems happen. It's because those elastic layers become stiff and there is buildup of calcium. Now, this can affect mostly 3 parts in the body. First one is the skin, then the blood vessels, and well, the eyes. The onset of the disease is typically around 13 years old. It starts with the skin. After that, usually comes the eye condition, and a little later comes when it affects the blood vessels. So when we look at this,
you usually, if you were to find this particular case and you were looking at different perspectives here, do you usually get the patients to the primary care physician and state, please rule out, PXC and so on and so on, or do you order any particular testing at hand What do you usually use in these kinds of patients, since there is a
Well,
large portion that do have underlying disease?
yes. So understanding the disease, the skin condition doesn't really have side effect. The cardiovascular, the blood vessels may have complications.
Exactly.
So the test for this is genetic testing. If there is no clear lesions on the skin, that would be genetic testing. I could send to the PCP, say, hey, I'm suspecting this. Can you do a genetic testing? And I will also refer them probably to the cardiologist just to get a baseline evaluation.
And that's
So
a great way. I think that's fantastic. Another, just a typical approach, you can't send it to the PCP, giving them your, not necessarily the mnemonics, but lay out the particular conditions. Let them stay on top of it, because sometimes, like you said, the cardio, excellent point, and that's probably the worst part, but not everyone remembers there is a cardio etiology with this particular one. There is a dermatological etiology. So if you leave it to the PCP, then the PCP can move forward and go, okay, I need to do calcium testing. I need to refer it to the cardio, because then they got to kind of bring a team about, depending on the entity.
Yeah.
That was a great point of you letting them know that there are different systemic variations and they can lead to different kinds of problems for each one of these that you're going to be discussing.
yeah, yeah. Okay. So looking at the skin, this is an important finding because it's actually something we can pick up. The lesion will look, they can look small and yellowish, but most importantly, we'll have what we see here on the picture. It's cutaneous laxity in location where the skin folds. That can be the neck, the armpits, or the knees, and it's typically asymptomatic. It's mostly a cosmetic problem. Now, for the blood vessels, again, those arteries, they need to be somehow elastic to withstand the pressure as it goes through. And mineralization of those connective tissues in the arteries can cause quite some complications. Here are the complications. We can have intermittent claudication, which is painful cramping when they exercise. They can have peripheral artery disease, occlusion of the cerebral arteries, which is essentially a stroke, and occlusion of the coronaries arteries, which is a heart attack. Now, the ocular manifestation, there are multiple. One of them is peau d'orange appearance. I like to say peau d'orange, Diana, because it's my language. It means that the retina kind of like look like the skin of an orange. You can see it here. And it's caused by diffuse alteration of Brooks that leads to overlying RP modeling and a granular appearance. You can see it right there. Now, they can have, of course, angioid streaks, and this can be complicated by choroidal neovascularization, which can lead to hemorrhages and subretinal scar, which we'll go into in just a second. Now, other possible findings in those patients include optic nerve head drusen and peripheral comet tails. This is the picture we have here. And this is really just a focal calcification of Brooks membrane in the periphery. Now, we got to be careful about CNVM. This is the most problematic complication those patients can have. When there is a break in Brooks membrane, this allows for proliferation of the blood vessels from the choroid to the subretinal space. Now, any condition that has a break in Brooks can cause a CNVM. And here are some examples: choroidal rupture, histo, that can be macular degeneration. Wet macular degeneration is a classic one, and of course, angioid streaks. Now, the importance of Brooks. Brooks is a very thin layer, but it's extremely important to maintain the integrity of the retina. Brooks is really the barrier that separates the choroid from the retina. And when there is a disruption of Brooks membrane, it will disrupt the exchange of like nutrients, oxygen, waste products, etc., from the choroid to the retina. And as a response of this metabolic stress, pro-angiogenic factors will be secreted to kind of like heal that area, such as the popular VEGF. Now, we know what VEGF does. VEGF promotes the growth of new blood vessels. But the problem with those blood vessels that we call neovascularization, they're immature and they cause more trouble than actually helping. So here's a good thing. I've dived into this to find why every time we have neovascularization, it comes with fibrosis. Because no one ever really explained that fibrotic part. They just say, okay, VEGF, neovascularization, and then you get fibrosis. So why does the fibrosis happen is the explanation. So as there is a formation of neovascularization, fibroblasts, they are recruited from the choroid. Now, the role of the fibroblast is to help in the healing process of that damaged area. And the fibroblasts will produce this extracellular matrix protein like collagen and fibronectin. Over time, this protein will kind of like get together and they will form a fibrotic scaffold around those new blood vessels. And that makes sense because those blood vessels shouldn't be growing just in an empty area. They need structure, they need support. So that's why those fibroblasts bring those protein to provide support to those new blood vessels. So as this fibrotic membrane happened, this is what we see as subretinal scar. I put two pictures here of one is a subretinal scar that we see in a patient with macular degeneration. The other one is diabetic retinopathy, because we often see fibrosis that happen in diabetic patient in PDR, and you can see that the fibrosis follows the area of neovascularization. And this is because what I just explained with the fibroblast is the same mechanism. So neovascularization doesn't happen just on its own because it comes neovascularization plus that fibrotic membrane, and all together it's called fibrovascular membrane. And that's why it gets so complicated.
And on the bottom, bringing back your PVD, I think it's a great example. So you got that fibrosis there, you got the vitreous producing a scaffold between the posterior hyaloid and that fibrosis. So what necessarily can lead to this particular patient when they build the fibrosis in a proliferative diabetic ret? They're likely to deal
in the PDR, well, that fibrosis, because it's on top of the retina, it will contract and pull on the retina. So exactly you get attractional retinal detachment.
A little bit different than the obrigomatogenous ones, but it kind of brings it a hold to what you were originally talking about, the PVD, and bringing this perspective into a different RD because it's a different dynamic producing a scaffold. Excellent.
Yeah, and even sometime when they get that fibrotic membrane from a PDR, they will not only get the tractional retinal detachment, but also it can cause a tear that will complicate it even further by regmatogen. So they can have a combo regmatogenous tractional. Exactly. So fibrosis, and what's interesting to know is the neovascularization comes alone first and the fibrosis comes after. So if you catch it at a stage where it's only neovascularization, it's a very sensitive time that you can treat with anti-VEGF and prevent all this complication to happen. Because once you get a fibrosis, it's really complicated to deal with those patients and solve their problem when it could have been a simple anti-VEGF injection earlier.
My surgeon used to say, not the current one that I work with, but my old one, is to try to take a piece of chewing gum, put it in a tissue, and now try to easily remove that chewing gum from the tissue without ripping the tissue. That's the kind of surgery you got to do with those.
That's a good analogy.
You mentioned about anti-VEGF, because obviously I came from an era a while back when there was no anti-VEGF. But now, Streamline, we certainly try to do anti-VEGF. Now, when you get to that fibrotic stage, if there is traction within the fovea area or the macula, you got to be really careful with injecting the patients. Because when you inject the patients, you get exactly what you were talking about. The vitreous will contract because it's a crunching effect from that gel that you're putting into the eye. And that crunching effect in and of itself can actually cause a rip, causing a retinal detachment. So when you have a lot of this preglial fibrosis around the macula, you got to be a little bit careful. And oftentimes they'll use a combination both of injection and PRP to address the VEGF growing forward, kind of arrest it as much as you can, and then the continuous growth that you had mentioned before with the VEGF growing.
Wow, so it's really complicated. Which poison is the least damaging, right?
Yes,
either you do the membrane pull or you cause the trouble yourself with injection. Wow.
Exactly. But that's usually when the traction is back up. But those are great pictures and great clinical pros there, bringing it right back to the whole PVD process. I really like that.
Right. All right, so complication of CNVM, we know this. It's leakage and hemorrhaging. We have here an OCT with a membrane. You can see the reflectivity of the CNVM. It's kind of like hyper-hypo because it's a net. And we can see the subretinal fluid that is nearby. This is caused by the leakage from the CNVM in the subretinal space. Now we can have, of course, a subretinal scar as this fibrotic tissue happen. You can see the reflectivity of it is much denser because the scar has, well, a denser it's a denser material, so it have a brighter reflectivity on OCT. Subretinal fluid, as we can see here above, will reduce visual acuity. However, a subretinal scar will reduce the visual acuity even more. And the problem is, once the scar is there, it's irreversible. So this is very problematic. All right, so back to our patient. We said that this patient presented with reduced visual acuity in the left eye, a large subretinal scar, and angioid streaks. Now we kind of know what happened. The suspicion was angioid streaks secondary to Pseudoxanthoma Elasticum. And well, now that we know how this disease goes, how can we prove that in office? Because I'm not going to do a genetic testing right now. Is there a way I can know if it's pseudoxanthoma, since it's the most commonly known underlying condition? Well, remember those skin lesions? So here it is. This is the patient. I say, hey, can I see your neck? Look at the neck, and you have this like weird folds. This is most likely confirming the diagnosis of Pseudoxanthoma Elasticum. From here, I referred him to PCP, cardiology, dermatology might as well, and most importantly, to the retinal specialist. So the management of this condition, refer the patient to rule out active CNVM. They will do an OCT, OCTA, or FA. If CNVM will be present, they will inject anti-VEGF. And if it's not present, they should monitor very closely, especially the good eye, to make sure CNVM does not happen. And if it does happen, this patient will need an injection. And as I said, when there is a subretinal scar, the visual acuity is the vision loss is typically irreversible. So that left eye is kind of like, it's kind of gone. We need to be really careful that that right eye doesn't develop a CNVM as well, because at that point, you will lose vision in both eyes, and that will be kind of like the end of the road for him, and that will be low vision. So refer him to the cardiologist, dermatologist, and well, genetic testing if you want to confirm the diagnosis. So as a conclusion, Pseudoxanthoma Elasticum is a genetic condition that affects the elastic tissue. It has the most impact in the skin, the blood vessels, and the eye, especially Bruch's membrane. Now, there's no cure for this condition. The main treatment for the eyes is anti-VEGF as soon as there is CNVM, and lifestyle changes, because a break in Bruch's membrane in angioid streaks put the patient more at risk for complication in traumatic injuries, right? All right, any questions so far? All right, if there's any question, please, Sammy, let me know. I'll try to answer them as I can. Let me see here. Do we have any questions here? No, we don't. Okay. All right, let's get back here. All right, now we'll take a break a little bit of the hard knowledge. We'll do something a little fun. This is a topic people have shown a lot of interest, is how to take beautiful pictures of the anterior segment and the retina using your smartphone. So we'll start with slit lamp photos and videos. You can really take beautiful pictures of the eye using simply your phone. Here I'll show how I do it on my iPhone. I'm pretty sure the features and are similar on Androids or Samsung. So we'll start with going handheld versus using the adapter. The handheld technique is quick. That's the good side of it. It's quick, it's efficient. However, the downside of it is that it's unstable, and it requires a little bit of skills for to maintain stability for this. And also, it looks a little less professional because you pull your phone in front of the patient. Now, here's a pro tip. I use my finger. You can see here, once I find the sweet spot, because there is a sweet spot, in fact, it's called the exit pupil. Once you find that spot, I use my finger to maintain that ideal distance. And that's where I hold my phone for the rest of the exam to take my photos. Now, I also use a pop socket. This is this thing here. It helps me a lot in doing my exam with one hand, because I have one hand on the slit lamp. The other one is I use one finger to hold the pop socket and the other one for the distance for maximum stability. So here's a video of what the handheld look like. I hope it's not going to come out too chopped. Let's see. All right, let me put it here from the beginning. Here we go. So you open your phone, you put it on photo mode. And then after that, I'm maintaining the distance with my finger. You can see it's somehow stable. And when I have a good shot, I take a picture. Now, here's an interesting thing. You should use the zoom that you find on your phone, which is the ×1, ×2, ×3, because those are optical zooms. You don't necessarily have to reach for to the slit lamp to increase the zoom over there. Those are optical zoom and will maintain the good quality of the image. If you zoom with your fingers like that, this will be a pixel zoom and it will lower the quality. I'll let you show here. Now you can see my working distance. I have my finger that holds the distance and stability as well. And you can go on different type. You can go on optic section. You can go retro illumination, whatever you need. And you can also switch from one eye to another, maintaining that stability as you go. All right, let's see here. All right, so if you want to use an adapter, the adapter is a great option. It provides fantastic stability. You can have both hands free. It looks certainly more professional, and it's very affordable, actually. The only downside of it, and this is the big downside of this thing, is it takes time to put on the slit lamp. This is one of the main reasons why I don't use the adapter, because sometimes I see something cool on a patient, I want to grab a picture. I don't have time to put my adapter, lock it, turn it, adjust it in front of the patient. So most of the time I go handheld, unless I know that the patient is coming with something interesting. So I take the time to mount it on the slit lamp. Where you can find it on Amazon. You can see it's $20. And here is what it looks like to put the adapter on the slit lamp. Let me see here, so it's not too chopped. Just a second. Here we go. So there are screws on the adapter. I put it really at the edge of the slit lamp, within where the plastic is, because it needs to be not too close to the ocular. You tighten that that top screw. After you do this, you pull out your phone. Usually you should put it already in photo mode, so you can adjust the alignment between the camera and the opening of the ocular. You can see here. And you tighten that screw here, so then the phone is stable. There is another screw at the back, which also maintains the rotation. And you can just lock it here, and then you can adjust it, because he has like some axis of rotation. You can see here, I adjust it here, done. Once I got that opening, that's where I lock it. And after that, well, both hands are free. You can see here, you can see that I leave some distance here. You can see I leave some distance from the camera to the ocular. I don't stick it to the ocular because I will lose peripheral views. I will show you why in just a second. All right, so of course I had to bring some theory in this. I couldn't just tell you, just take a picture and that's it. The ability to take a picture, a good picture in the slit lamp, depends on whether you can or you cannot find the exit pupil. The exit pupil, if you remember a little bit of optometry school, that's the virtual aperture of the optical system. And typically it's somehow somewhere in the ear, just in front of the slit lamp. We do it naturally. When we look in a slit lamp, we don't stick our eyes to the oculars. We pull back a little bit to reach that maximum field of view. Now, here's a video. I know it's a little silly, but it's good to see one time just to understand. There we go. So you can see here, I'm getting close. I see the opening. I'm reaching the exit pupil. I have the maximum field of view. Now look what happened if I push even more. That's it. Look at my view now. I'm losing a lot of view because I was not at the exit pupil. So I pull back, I go back in, and I will stop here. Whether if I'm holding the phone with my hand or if I go with the adapter, that's where I lock my phone. So not too close, not too far. All right. Oof, I put a lot of videos here. So this is very important. The ability to deactivate the camera switch. This is probably the most important thing you can see that new iPhones or new phones in general, they have multiple cameras. And the problem with this is that those multiple cameras will switch automatically as you get close to an object or if there is something obstructing the view. So look here, I put my hand, if I get a little closer, the camera just switch, and it shows me here that the camera has switched, and this in front of the slit lamp will cause problem because it will take away the alignment you got. So you see here, it will activate itself. When it activates, you click it, done. And it comes back to a single camera and it won't play with you anymore. Now, after you've done that, there is a second thing you need to deactivate is the long exposure mode. This is also a functionality of the new phones. And this is made in order, so when you take a photo in dark condition, the phone can get the maximum amount of light to get the clearest and most luminous photo. However, this will cause blur in the photo because as you hold it, the picture will be taken over 2 to 3 seconds. And if you move a little bit, the image will come out blurry. So 2 things you need to do: deactivate the automatic camera switch, deactivate the long exposure mode. And then it's up to you to just take beautiful photos and look at what you can take. You can take retroillumination, you can take some staining of the cornea, very zoomed in picture, or here a beautiful picture of a corneal transplant. All right, so how do you record videos in the slit lamp? It's pretty similar. The only thing you need to know is it's really difficult to capture a video if you're just holding the phone. It's possible, it's difficult. The best way to capture a video is to take the time and put the adapter. And once it's on, you can take great videos. And you can also take pictures or videos of the fundus with a 90 diopter. However, the quality will go down a little bit. Now for the interesting part, how to take fundus photos and videos of the posterior segment with your phone. All right, so the basic setup is similar. You will need to deactivate. Usually I put my hand and I just deactivate that function of camera switch, and you will need to activate the flash. Now, so how does that work for holding the lens? It's pretty similar to BIO. You just pull the lens, you set up your phone. Imagine the phone is replacing your helmet. And then once you have that red reflex, you can pull the lens and get a view. Now, the working distance is the most important factor in taking a video or a photo of the fundus. You need to extend your arm. You see here, I get too close. I will never be able to capture anything at this distance. This is way too close. What you need to do is to pull the phone as far as possible. As long as you can see what you're doing, this is as far as I put it, as I pull it. So first you extend your arm, then you will zoom in, and then you pull the lens. Let me show you in real time how it looks like. And of course, this video was recorded with the patient permission. So here it is. I put my lens, I zoom in 1 time, I zoom in 2 times, I have my red reflex, then I pull the lens and I can get a view. The longer you can maintain the view, the clearer the image will be, because the phone needs some time to focus on the area of interest. And also the fact that you're zooming in will prevent the phone from focusing on other things that can distract it, like the wall behind the forehead of the patient or something like that. So let me show you one more time. You put the lens, you zoom in 1 time, you zoom in as much as possible, and then you pull the lens. And this was somehow in the periphery, so the periphery is definitely recordable with the smartphone. Now, I believe the next one is troubleshooting. Yes, so troubleshooting, let me put that video. There is also audio on it, so enjoy the tutorial. All right, so today we're going to see how to record your fundus finding using your 20 diopter lens. All right, so today we're going to see how to record your fundus finding using your 20 diopter lens and your smartphone. The first thing you do is you put your phone on video mode and put the flash on. After that, place your 20 diopter lens in front of the patient and pull the lens until you see the retina. Now, the thing you don't want to do is get too close to the patient, because you can see here there's only a tiny sliver of retina available, in which I'm going to try to feel the lens. You can see I'm pulling, and it's really difficult to get a view. Now, when I
pull back my phone away from the patient, you can see that area of retina is much wider. Now I can pull the lens and have a much clearer and wider view of the retina. So really the most important factor is at what distance you're holding your phone. You see here I get too close, that area of retina is almost non-existent. It's going to be really difficult to feel the lens. But when I pull my phone as far as possible from the patient and then I pull the lens, it's much easier to see the retina through your phone. All right, I hope you guys find that useful and I see you on the next one.
All right. I hope you guys understand. Of course, if you have any questions, feel free to ask. All right, so fundus photo, this is the last part. Fundus photo it's a difficult technique because if you pull the lens, if you put your lens and you try to take a picture, the phone doesn't know where to focus yet because there is no light. So the best way to do is to take a video like I just showed you. And after you're done taking the video, you just go through that video and you screenshot that moment of interest. Yes, it won't be the highest quality, but at least you have a perfect picture of the area of interest right here. All right. Of course, feel free to ask questions if you have some. All right, so we'll go now in the second case. It's called a melanoma masquerader. This is a 19-year-old female who presented for comprehensive eye exam. Her chief complaint was blurry vision at a distance without glasses. She had no family history. She had no relevant past medical history, no allergies, and no past ocular history. Now, the entrance testing was pretty unremarkable. EOM were normal, vision was good, confrontation field were full, pupils were normal, and her best corrected visual acuity was 20/20 with a low myopic prescription. Her eye pressure was normal. Anterior segment was normal as well. And her fundus evaluation, the optic nerves looked pretty normal. The macula was clear, the blood vessels were normal. The posterior pole was normal as well in both eyes. And when we looked at the periphery, the left eye was normal and the right eye was not. So now that we know how to take a video of the fundus using our smartphone, how about we see a live video of this finding? All right, there we go. All right, just a second. Here we go. Let me put it here. Here we go. So we are seeing this area here. That's the area of interest. You can see that it's a little pigmented. It's slightly elevated. If you can see, the blood vessel is kind of like going above. It takes a turn a little bit. That indicates that this is elevated, right? Hey, pretty good video for a periphery, huh? All right. So here's a picture of the lesion. You can see it right here, right? And the picture was about 2 to 3 disc diameter. It was slightly elevated. It was in the mid-periphery by the vortex vein. So as we said, it's lightly pigmented, right? There are no overlying lipofuscin, no visible drusen, and no appreciable subretinal fluid around that area of interest. It appears to be deep within the choroid. And what was interesting is how I saw this as I checked the patient in the sitting position. I could see the lesion. That's when I took the video. And when I said, well, you know what, I'm going to take a better look. I'm going to lay down the patient. So I lay down the patient and I try to find the lesion and I can't find it anymore. So this is very interesting because it's one of the key findings in this lesion. So the differential diagnosis for these type of choroidal tumors include several life-threatening conditions that include choroidal melanoma, choroidal metastasis, meaning cancer somewhere in the body that just traveled to the choroid, lymphoma, and there are other benign choroidal lesions that can be possible, like the choroidal nevus, and in some rare cases, vortex vein varix. Okay, so melanoma masquerader, Mr. Choroidal vortex vein varix. So what's a varix? A varix is an abnormally dilated vein. You can see it here. That's what it looks like. Okay, let's close this. Abnormally dilated vein compared to a normal vein. Any result for, well, weakening of the wall or long-standing increased venous pressure. And it can happen in multiple places in the body. The most common we know is the varicose vein that we see in the legs, right? It can happen in the GI as a gastric varices. It can be a venous malformation, and in some cases, it can happen in the vortex vein, and at that point, we'll call it vortex vein varix. Now, vortex vein varix is a bulging of the vortex veins. The etiology is unknown. It's typically lightly pigmented, and the size can range from 1 to 3 disc diameter. The important thing about this lesion that kind of like separates it from other condition is that it has a dynamic feature. And it can be flattened on scleral depression. I mean, if you take your depressor and you place it just above that area and you press on it, you can see the lesion will go flat. So that's very specific for that lesion. And it can also change in size based on the posture of the patient. Like I said, the patient was sitting, I could see the lesion. The patient lay down, I could not see the lesion because the fluid kind of shifts, right? And this is one of the key features of this lesion, right? Has very little to no risk of thrombosis. And well, it can simulate other choroidal tumors, which have significant clinical implication, like melanoma, for example. That's why it's so important to differentiate this condition from other potential malignant conditions. So we said the lesion is dynamic. Like I said, the seated position will show one aspect. The lay down position can shift the fluid and make it disappear. And that's because, well, the lesion is filled with fluid, and the fluid will shift with gravity depending on the position you're taking. Also, it depends where is the lesion. Is it superior, inferior, etc., right? So diagnostic test in vortex vein varix. Like I said, scleral depression is a quick and easy way to assess that area if you suspect a varix. Like I said, you place your depressor just above that area. If you can reach, you press on it and it should go flat, kind of like disappear, right? And that's one of the diagnostic tests for vortex vein varix. Now, ICGA is probably the best test you can do for this condition because ICGA is made to image the choroid. So we have fluorescein angiography, but ICGA is specifically made to image the choroid because it has better penetration, longer wavelength, etc. So you have here a presentation of a patient with a vortex vein varix. You can see it here, lightly pigmented. And you can see that on fundus autofluorescence, it's really difficult to see it. We see it because the fluorescein does go to the choroid, but it's kind of like masked by the overlying fluorescence from the fundus fluorescence, the FA. The retinal fluorescence, sorry. Now, if you do ICGA, well, you can see clearly the choroid, and actually you can compare that area, which is the normal vortex vein, which does lights up, but not as much as the vortex vein varix, because the vortex vein varix has more blood and, well, more of this indocyanin green dye, so then the lesion will lights up even more. Now, B-scan ultrasound, if you have an ultrasound, that's a good way to evaluate that lesion as well. And we will use the fact that the lesion is dynamic in order to kind of like differentiate it from something else. And you will place the probe on the patient and have him look in different position of gaze. For example, here you can see a patient that is looking down. The lesion is right here. The thickness is this. And you can see that as the patient looks up, the lesion is way flatter. So you can see it thicker here, it's flatter here, and again, is the dynamic feature of the lesion. And then OCT, well, OCT is not always achievable because sometimes it's far in the periphery. But if you can run an OCT over that area, you will see that the inside is hyporeflective because, well, it's fluid. It has very low density. The surface will be smooth, and, well, the overlying retina will be pretty unaffected. So coming back to our patient, a 19-year-old asymptomatic female came for a regular eye exam. We found on the fundus evaluation a lesion that is compatible with vortex vein varix. Now, we can just say, oh, it looks like a varix, I'm just going to monitor. Because of the seriousness of the other potential conditions, you still have to rule out those other conditions just in case. So I sent a patient to the retinal specialist. He's done a few tests on her, and this is his report. 2 to 3 disc diameter, lightly pigmented lesion of the peripheral choroid in the right eye. The lesion goes flat on scleral depression and lights up on ICGA, which is diagnostic. And it's compatible with vortex vein varix and will monitor. So a benign lesion that kind of looks a little scary because it mimics melanoma or stuff like that. All right, so conclusion on vortex vein varix, it's a benign condition. It's often mistaken, or it can be mistaken for serious life-threatening condition like choroidal melanoma, metastasis, etc. And this is why we call it the melanoma masquerader. Imaging in this patient is key, right? You should do a B scan, an OCT, or an ICGA if you can. And fluorescein angiography is not that useful in this condition. Scleral depression is a quick and easy way to assess that area by trying to flatten that lesion. All right, any questions?
Hey, Dr. Fitoussi. So we do have one question. Actually, two. Do you do bio with phone with room light on or off?
One more time, can you repeat that?
Do you do bio with phone with lights, the room lights on or off?
You're talking about with the smartphone?
I think so, yes.
Yes, I go lights off. You could go with lights on, but you will have reflections on the lens. But it's better to go with lights off. It's similar to a regular binocular indirect ophthalmoscopy. That's probably the best way to go. Let me open it here so I can see you guys. Here we go. So yeah, lights off. Do it the same way you would do BIO. It's the best to avoid reflections, and yeah, that's about it. Any other questions?
Perfect, thank you. And then I have two more questions. One, it just says, is it rare? I'm not sure.
What's rare? Are we talking about vortex vein varix?
If the follow-up comes in for that, I'll definitely let you know, but we can move on to the next question for now. Can you please explain how to perform scleral depression?
Oh, scleral depression. So scleral depression, there are different types of depressor. You have some that are more flat, more round. Typically, the way to do it is to have the patient look in the opposite way where you want to depress. For example, if I want to depress the superior retina, I'm going to have the patient look down first. I place my depressor in kind of like the crease of the eyelid. And then I'm going to ask the patient to look up. So then my depressor is kind of like stuck in that area of interest. I hold it there. He will look up. I hold the depressor here. And then I will indent. And well, with the other hand, I'll put my lens and take a look at it, right? And you can adjust the depressor as you're doing it. So you start to depress, and you can adjust the depressor as you do your exam to see the area of interest. You don't have to press really, really hard, right? Because I see people they're pressing really hard, it hurts. Also, some people will put piperacin to make the patient feel better. It doesn't really work because you're pressing behind that area where the piperacin cannot reach. So the numbing effect doesn't go all the way at the back, typically. So press gently. If you get a good angle, you'll see that area of interest, no problem. Yeah. Any other questions?
Okay, perfect. So yes, that question, there was a follow-up. So is it rare? Yes, it's in regards to the varix.
Yes, vortex vein varix is not very common. Actually, those are really the only one I saw. They are not common, and I will tell you better than this. Not only they are not very common, but also if you perform your exam in the supine position, in the laying down position, you're likely to miss it. And it's very interesting because when I did the exam, I always lay down the chair, almost always. I don't perform my exam sitting because I don't think I can get good angles like that. So I lay down the patient so I can do the best fundus evaluation and reach the periphery. But for some reason that day, I did my exam sitting, and I think because the patient was seated, that's how the lesion was more visible. So you should take this in consideration as well, that if many of the exams are done laying down, probably a bunch of the varixes are missed. But luckily, it's a benign condition, and it won't cause any trouble really. But not only it's rare, but the position taken can lower the rate of how common it will be found in those patients. Yeah.
Awesome, thank you. And we actually do have a couple more follow-up questions. We're getting lots of
Sure.
engagement here. So the next question is, what is the prevalence of varix?
Oof, that's a good question. I honestly don't know. I'll have to look it up and find it. I'll get back to you. Whoever asked this question can write to me and I will find this information. I don't think it is very prevalent. I don't think it is. No.
Okay, thank you so much. And the last question we have so far is prognosis worse when waiting a long time to get ERM peel versus doing it sooner? And then in brackets, does the surgery become more complicated if you wait too long?
Not necessarily. So ERM can go three ways. When an ERM develops, it can regress on its own, it can remain stable, or it can go worse. So really the way to do is to wait and see what happens if the patient has reasonable visual acuity and if it doesn't affect too much his, if it doesn't cause a significant metamorphopsia. So waiting is definitely not a bad idea. In fact, waiting is probably better, depending on how bad the vision is. But if you have a mild ERM, I would say wait, see what happens. If the vision remains good, don't touch that eye. Think about it. It's a whole invasive surgery. You have to go in, do vitrectomy, peel the membrane. It's invasive. So if it's not that impressive and it doesn't affect visual acuity, let it be. But if you see that it's significant, and sometimes you saw in those cases with ERM that they kind of like tear apart the macula because it is a very thick membrane, well, that might be the time to go and consider surgery. So wait as long as it's not too impactful on the macula. Wait less if you see that it's getting complicated over time.
Fantastic.
Right,
Thank you so
else?
much. If anybody else has any other questions, feel free to drop them in the Q&A. We're on quite a good roll here.
I don't see the question. Where are they? They're on the.
So at the very bottom of the Zoom ribbon where you share your screen, to the right of it.
Oh, here.
Yes.
The chat.
So yes, exactly. So there's three tabs: open, answered, and dismissed. So the ones you just answered are under dismissed.
Oh, here. Wait a second. Nope. That's okay. You can just tell me the questions.
Yes. So I don't see any other ones that have come in as of yet.
All right. So we're what? We're an hour and 37.
We're at an hour and 40, which is exactly how much time you would need to be for content. And then for every hour, 10 minutes of Q&A, leaving the floor open. But if anybody else has any questions, feel free to drop them in.
Sure, and it can be a question about anything, please feel free.
Thank you. I appreciate it. Well, I guess I have another question here. Somebody's asking is how can they access your videos?
Which videos?
I'm assuming your social media videos that you have.
Social media, you go online, you type interesting retinal cases. It's on Instagram. And well, let me try to pull it up again so you can see the.
Yeah, if you don't mind maybe pulling up like the Instagram handle or link for people to be able to view, that'd be great.
Damn, I didn't know I'd be advertising my Instagram on the CE.
Well, your content's great, and if people can learn more and see what's circulating out there, that'd be great.
Right here.
I have another question.
Kind of like switch the the tendency of social media just being for fun to somehow educational. Here, I'll do it like that.
Perfect. Thank you.
Cases.
And then another question is, what is your typical follow-up for lamellar holes?
Lamellar holes. Well, let's look at it this way. A lamellar hole, it depends on the cause, but let's say if it was caused by a PVD, and let's say the vitreous would have chopped that superior part of that inner part of the retina, it might just remain stable. And like Dr. Shechtman said, surgeons typically don't go in for this because the surgery, I don't think, will improve vision so much. And also you have to take into consideration that those patients with lamellar hole, they have reasonable vision. They don't have that drastic drop in vision like the full thickness. So I think this is the type of patient you can just follow, make sure it doesn't get worse. And if it's stable, especially if the other eye is okay, it's okay to follow them for a bit until you see that it doesn't change anymore. And well, you just keep taking a look once in a while at that thing. So Typically, you can initially you can follow up a little closer to make sure it doesn't change. I would say like follow up in 1 month, see if it doesn't change. And over time, you can just extend the follow-up to make sure it remains the same. Also, it depends on the visual acuity, right?
Fantastic. Thank you. Oh, we definitely have a few more coming in. Are nutrients helpful for ERM?
What's the question? Nutrients?
Yes. Are
So like food supplements?
let's see if there's a follow-up for that.
Keep along with that. Okay. Here we go. Okay, let me see here. Do we have?
If you
Okay,
need help finding
good.
it, just let me know.
I just have 3 here, and they were from. Okay, we have this. Okay, and what do we have here? We have a bunch here. Okay, so I see here, are nutrients helpful for ERM? I'm assuming you're talking about food supplements. Listen, the ERM is made by proliferation of the glial cells. Food supplement will not impact. I wish it was that easy, but food supplements will not impact the progression, where it is good or bad on that membrane. Yeah. Let me see. I'll look into the prevalence of the varix. Okay.
So if you take a look under the open tab, there are a few more questions.
These ones?
Yeah.
Okay, so Amsler grid. Amsler grid, it's funny because I went to school learning about Amsler grid. That was the way to go. Amsler grid is something you can give the patient to do at home to monitor themselves. You can look at Amsler grid from kind of like the opposite. It's the opposite of OCT. So OCT will show you objectively what's the distortion, what's the damage, and Amsler grid will show you subjectively what the patient sees. Now, yes, if you want to measure the metamorphopsia, it's kind of like the way to go. So you can definitely do Amsler grid for this. But if you have an OCT, I think most importantly, that's the way to go. And just as the patient, do you see distorted, right? And you can give them an Amsler grid at home, depending on what condition we're talking about. For the ERM, for example, and tell them, well, if you get worse, please come back earlier and we'll reassess. But OCT really gives you more information than the subjective Amsler grid. Okay, lutein is exenting omega-3. I'm not sure what's the question about because it's without context.
That question was in regards to the one asking is nutrients.
Nutrients.
Helpful.
Yeah, so that's those things are yes, they are the good supplement for a healthy retina. But the ERM is kind of like independent and will grow regardless of the health of the retina. So I don't think it will help. The lutein zeaxanthing is for the health of, we use them for macular degeneration, patient with dry macular degeneration, to make sure the retina remains healthy and kind of like to provide the maximum protection to prevent the disease to go further. But ERM doesn't have any implication or any relation to the food supplements. Macular degeneration, when you prescribe Ocuvite, which is the like we just said, the supplements, you can go pretty much on anyone that has dry macular degeneration. Listen, the goal here is to prevent further damage. You know that macular degeneration is an oxidative process. That's why what causes macular degeneration is sun, it's smoking, all those things are oxidizing factors. So what they did in the AREDS 2, those vitamins are 1, antioxidant, and 2, specifically lutein zeaxanthin. They're the supportive nutrients for the health of the retina. So I would say anyone with some type of dry macular degeneration, you can put them on the treatment. It's preventative, right? And when it gets to wet macular degeneration, there is no more use so much of those vitamins here. Okay, how do you confirm choroidal melanoma and what's the management? So choroidal melanoma, there are a few things you can do about it. One of them is assess the size and the depth of it, assess the progress. Is it getting bigger, yes or no? A few important tests include, obviously, OCT. You should do fundus autofluorescence because melanoma disrupt the waste process when the waste. So the photoreceptors in those discs, you have those discs are typically digested by the RPE. You see, those photoreceptors are sitting in the RPE just like that. And over time, after the metabolic activity, those products in those discs needs to be regenerated. So that's the normal process when the RPE kind of like digests those discs and new are being created with more metabolic abilities. So this waste product that's been digested need to be evacuated through the RPE. And this waste product that we call lipofuscin is hyper-autofluorescent. Now, in a normal retina, if you do fundus autofluorescence on a normal retina, you will have a generalized little bit of hyper-reflectivity on the retina, no reflectivity on the blood vessels and on the nerve because there is no photoreceptors there. Now, when there is a melanoma, the melanoma disrupts this activity, this waste product evacuation. So there will be buildup of lipofuscin on top in the RP in that area. So that's why fundus autofluorescence is important in patients with melanoma because you will see hyperreflectivity on top of this lesion. And if you look at fundus, just clear fundus, that's what we call the orange pigment. And they are different from drusen because drusen are like dot-like, and the lipofuscin kind of like fuses together. So lipofuscin doesn't have really a shape. It's more like kind of like scattered and fuses together versus the drusen are more, they're more like dot-like and separated by spaces. By the way, drusen are a fantastic thing. Drusen, they show chronicity because it takes time for drusen to happen. So that's why when we see drusen overlying an area of pigmentation, we're like, oof, that's a good finding because we know that this has been here for a long time, right? Lipofuscin is not. So if you see hyperfluorescence on top of melanoma, on top of a pigmented lesion, this is not good. So fundus autofluorescence. After that, you have B-scan. B-scan will show you internal hollowness, meaning the lesion will appear somehow empty inside. And there is a very interesting way to look at a melanoma with an ultrasound. It is not in a static way. You put your probe and you wait, and you will see pulsation within the melanoma, if it is a melanoma, because remember, cancer is highly it has a high metabolism. So because those cells are just, duplicating like crazy, and it needs high amount of blood supply. So when there is a melanoma, if you look on ultrasound, and if you stay there with your probe and you wait, you will see that lesion doing this. And that's also one way to use your ultrasound to kind of like differentiate melanoma from something else, right? Now, in those cases, when it's unsure, you can do a biopsy, of course. The biopsy will not tell you just cancer or not cancer. It will also tell you if it is cancer, what type of cancer is that? Is it a rather aggressive melanoma or is it a least aggressive melanoma? And then for the treatment, well, there's a bunch of treatment. Not that is what I don't really deal with this, but they can put a radioactive plaque, they can laser it, etc. But that's, I guess, the choice of the oncologist or specialists. I think that's about it. And then, well, on OCT, of course, melanoma will show, first of all, they will show elevation. This is something you measure with ultrasound, the height, the thickness of the lesion you measure with ultrasound. And on OCT, you can see subretinal fluid that will be most likely at the base of the lesion. This is kind of like typical in melanoma. If you have that bump that is like this, as it goes down and it meets again with the rest of the retina, that area, that's typically where the subretinal fluid accumulates. All right, let's see here. Okay, well, an optic nerve that I suspect for papilledema. Listen, I live in the US, I see a bunch of obese people. So when you see a swollen optic nerve, or what you think is a swollen optic nerve, of course you suspect papilledema, because you know why papilledema happened. It happens because of increased intracranial pressure. And by the way, it's thought that the pressure increases within the cranium because of the compression of the spine, because of the extra weight, which prevent the flow between the fluid in the brain and the spine. So that blockage, because of the extra weight, kind of like increases the pressure up there. Now, does it come with symptoms? This is very important. Sometimes you look at a patient and I'll see those margins and I'm like, is it blurry? Is it not? I'm not sure. Ask the patient, do you have symptoms? I mean, if a patient has papilledema, he should have some type of symptoms. That can be the whooshing sounds. That can be the transient vision loss or osculation, meaning they change position. They will bend down, they will bend over, and the vision will go away because the pressure just accumulates on top of the nerve. It will kind of like shut down the circulation. Vision will go gray or black. And as they stand up, the pressure will go back down and they will recuperate vision. That's transient visual osculation. That's one of the big symptoms. And of course, you have headaches, right? The headaches, they're kind of like pressure because, well, there is pressure. And the whooshing sound. Do you have whooshing sound? So to tell if a patient has papilledema, I would say, first of all, do you have symptoms, right? Number two, any change in your weight. You need a significant change in weight to cause papilledema, right? You need, if the patient says, oh, you know what, I gained like 50 pounds in a few weeks, a few months because XYZ, that's also a risk factor, right? Patient is pregnant, you know that papilledema is more prevalent in pregnant women because of the drastic change of weight, right? And well, the way to go is to do an OCT, OCT GCL RNFL, and the RNFL at the optic nerve will tell you if this is likely a papilledema or if it's a false papilledema, which could be optic nerve hair drusen. I have fundus autofluorescence most of the time. When I see a nerve with blurry margin, my fundus autofluorescence will pick up those drusen because the drusen in optic nerve hair drusen, they are autofluorescent, and you will see those things lighting up within the nerve. So that's one way to just quickly rule it out. And you can see also a B scan. The B scan will show that dense reflective calcific drusen in the optic nerve. That's also one way to rule out what we call a pseudo papilledema. And the last thing, there are other causes of swollen optic nerves because of increased intracranial pressure. The patient does not have to be obese. Some patient can have increased intracranial pressure secondary to other causes. I've seen last time a patient with a Chiari, and because of this, it was blocking the circulation of the fluid, and pressure went up, and he was a skinny patient. But we could only pick it up on an MRI, right? So if you doubt MRI, you should send to neuro-ophthalmology if you doubt it, right? Unless you deal with it yourself. Let's see, what else do we have? I don't know about this. Do all retinal surgeons learn how to treat melanoma? Or does it go into subspecialty, which is ocular oncology? From my experience, I did my residency at Bascom Palmer, where they have a specific branch for oncology. So over there, the melanoma were treated by the oncologist itself. Let me see, what else do we have? Okay, to clarify, retinal subspecialty, similar to how all optometrists learn about binocular vision, but subspecialized optometrists do BV. I'm not sure to understand your question. Okay, let's get back to it. How frequent is ocular melanoma? It depends on the demographic. The patient at risk is older, pale, fair skin, and light eyes, and living in a sunny country. So I got a patient today. He was very light skinned. He told me he has family history. Now, of course, there is genetic part of it, but it was also the environment. So if you're a patient that is light skinned, living in the sunny country, like here, Florida, or even in in Latin countries, that puts you more at risk. If you're more pigmented, you're somehow more protected than this. The specific number, I don't have it, but again, it depends on the demographic and the location where you live. So what's the percentage of me doing BIO with my phone versus the real the BIO with the headset? I always do BIO with the headset. I never replace the exam with my phone. Usually it's when I see something with the headset, then I pull out my phone right away. I just leave my phone next to it, put my phone and put a flash on, and I take a video of it. But in no situation my phone will replace my headset, and for the plain reason that number one, I can see better with I can move better with my BIO on my head, and number two, I get binocular vision when I use the helmet versus when you take a video, you get a flat image, so you don't have the 3-dimension. Okay, so this one I answered how to detect buried optic nerve head drusen. If they're really deep, ultrasound will go through everything and will get it. Fundus autofluorescence will not get it as long as it comes somehow close to the surface. So yes, if they're really buried, ultrasound is the way to go. Thank you. My pleasure, guys. Love your talk. All right. I love you guys too. And indication for scleral depression, flashing lights floaters. Simple and easy, right? If there's something you need to see in the periphery, if the patient shows up with flashing lights, scleral depress, right? And it's a good way to practice, right? Because you have to do it anyways. Listen, I understand scleral depression is a difficult technique. It's a little time consuming, but you know, those patients that present with flashing lights and floaters, they need a thorough evaluation. That's when you pull your depressor and you tell them, I'm sorry, I got to press on it. And you go and you press on that retina. That's about it. Anything else?
Thank you so much, Dr. Fitoussi. I don't see any other questions in the Q&A. That was a lot of questions you went through. Thank you so much.
Damn, guys, you sent me a lot of questions. I know I'm going to receive more questions on Instagram after that, but with pleasure. I'll try to answer every question I can.
Thank you. You've taken the time to answer them all. They've all been there, all 27. Thank you so much. Actually, there's one more. Can you explain what exactly I'm seeing with the depressor?
Well, you see that area of indentation. So the depressor is used to be performed for peripheral retina. You can't always reach the peripheral retina the way you want just by taking angles with your BIO. So what you will do, you will indent the retina. So then that area, let's say it's difficult to reach that place here, by indenting it, you will lower that retina and then you can visualize it. That's kind of like how you look for tear. You kind of like move it around in the periphery and you try to see if there's a tear that you couldn't reach by just tilting your head or taking a good angle. Yes.